Thank you, Anton. Your Eminence, Cardinal Taxon, Professor von Braun, dear colleagues, I'm very happy and very delighted to be here again and talk about the next international collaboration, which is Cancer Prevention Europe. And as the name suggests, this was inspired by Cancer Core Europe, because when we saw the value of the basic translational and clinical research to work together, we thought, oh, we as prevention researchers want to have the same. And this is when, after the EuroCan platform project, we decided in 2018 to establish this new network. Before talking about the network, I want to go back to, first of all, I'm coming from Ajax, so here's some figures. But I also want to make you familiar with the situation of cancer that we have here in Europe, and this is really, in a nutshell, all the data combined. So this is Europe, according to the WHO definition of, I think, some 47 countries. And it was estimated for the year 2018 that there were 4.2 million new cancer cases. And you heard yesterday from our director also these predictions over the coming years. And for Europe, this would mean 5.2 million in 2040. And this is the annual number of new patients. So if you add this up, that means about 100 million new cancer patients over the coming 25 years. If you're wondering why did I not update the figure from 2018, you can see I put the 2022 figure on the bottom of this slide because I also wanted to show you these predictions that we are making are unfortunately very accurate. So this 4.5 million that we measured for 2022 is practically exactly what we had predicted in 2018 for 2022. So maybe we shouldn't call this really predictions, but unfortunately, this is an advance notice of a coming reality. So on the right side, it summarizes what you also heard in several talks of the modifiable risk factors and what would be preventable. And if you look at the cancer burden in this kind of pie chart, then again, you see this 40% that we could prevent. For 50% of all the cancers, we don't know the causes. This means research into understanding the causes of cancer. Etiological research still has to remain a priority as well. And if you look at the causes that we know, you see this very big red part. And this is the tobacco, the smoking. So this is still almost half of all the preventable cancers in Europe that are caused by the smoking. And you see another really major contributor to the cancer burden. This is this whole kind of block of overweight, obesity, lack of physical activity, and unhealthy diet, which also makes up around 15%. Other contributors are the alcohol consumption. We heard about the several infections that contribute to the cancer burden, radiations, and here the major cause is the ultraviolet exposure. Occupational workplace exposures and environmental factors are estimated around 3% at the moment. And we also have a little, where we know the causes, but they are not modifiable risk factors. So that's also kind of a fraction. That is the genetic conditions, for instance, but also like the natural radiation that we know causes even cancer at very low levels. And here we can reduce exposure of people, but we cannot eliminate the risk factors. So there will always be something. But there's actually a landmark paper from 1982 by Dole and Pito. And they were the first ones to make these kind of estimates. And you see that the smoking was around 20% already at that time. And then you're asking, with all the efforts that we are making, the taxation, the secret packages becoming more and more expensive. We have these ugly pictures on the packages. A lot of things have been done, and you also hear people saying, oh, prevention works. So why is it still 20%? And this is because the absolute number of cases is a combination of two things. This is the risk of the cancer in the population, but it is also the population at risk. So even if your prevention is successful and reduces the risk in the population, if the population at risk is increasing, and this is what is massively happening in Europe, you end up with a higher number of patients. So the two figures that you see here are based on exactly the same underlying data. But the left side is how we usually, as epidemiologists, present the data. And this is because we are interested in the risk. So we kind of assume what would happen in the population if the demographic characteristics of the population would stay the same. And this is from the Nordic countries, and you see the red curve. This is the lung cancer risk, so very much related to the smoking in men. And you see that here we had the peak at the risk of lung cancer more or less in the early 1980s, following the really, smoking habits of the 1960s. And unfortunately, in women, you see a steady increase in the lung cancer risk even. And if you look at the absolute numbers, then you see that, unfortunately, in the men, this positive effect of decreasing the risk does not translate in fewer patients, because due to the population size, but even more so to the aging of the population, and that we know that cancer is mainly a disease in the more elderly, the whole prevention effect is compensated by this increase in the population at risk. And you see also an increase again in the numbers of lung cancers in men. But what you see is really alarming is this very steep increase in the lung cancer burden in women. So in fact, the highest number of smoking-related lung cancers was not in the 1960s or 70s when everybody was smoking. The highest number of smoking-related cancers is now. So what makes prevention so difficult, given how much we know about how we could prevent cancer? And one problem is really that, your prevention, that it takes a long time until your prevention actually translates into fewer patients, because there's a very long duration between the time of the relevant exposure and the occurrence of the cancer. Think about the skin melanoma, where we think that actually the sun exposure as an adolescent is one of the major risk factors. But then melanoma occurs also at the ages of 60, 70. So there's almost 50 years between this relevant exposure time and that the cancer occurs. And the example that I'm showing here is actually the number of deaths from mesothelioma. And this is a pleural cancer, and we think it's practically due to only one exposure, and this is asbestos. So this is the number of asbestos-related cancer deaths in Germany for the years 2000 to 2030. So again, there's also some prediction involved here. And asbestos was banned in Germany in 1993. And you see that the number of asbestos-related mesothelioma deaths is increasing until the year 2020, when it starts leveling off and actually decreasing again. And asbestos is an extreme example, so we know that here the duration between exposure and occurrence of the disease is also especially long, but also for smoking and many other risk factors, we are talking about decades. So if you want to convince the policymakers to do prevention, it's not like in COVID, where you had an increase in the incidence and then they did a lockdown, and 3 days later the incidence was decreasing. When you tell a politician here, oh, you have to invest in this prevention, and they say, okay, when can I announce a success? You have to tell them, oh, we come back in 20 years, and then we can talk about it. And that's not very sexy, because you have to do the investment into the prevention today, but the benefit comes very much later. On the other hand, waiting longer and having someone who comes to the academy here and gives the same presentation in 2050, this is also not what would be helpful. And what we also should not forget, a ban of the asbestos is of course very important, and also bans, protection limits, but it's not removing the exposure. So we did in 2010 in the Lyon region a household measurement of household dust, and we found DDT in a really significant portion of households, which is a pesticide that has been banned 30 years ago. And the reason is, when there's a law saying we are banning DDT, the DDT is not saying, okay, I leave the country now. The DDT is staying. And when we are talking about something like the PFAS in the general media, they are called the forever chemicals. And I think from prevention point of view, this is telling. They're staying forever, unless in addition to the laws, you're also doing remediation and the cleaning up of all these exposures. So that's also what we have to keep in mind. So the components of the cancer prevention, really to remind you all, it's this kind of 3 steps of research. It starts with the etiological research, and it's getting more and more complicated because it looked like many of the major risk factors we have identified. So now we're probably talking about risk factors that is a combination of exposures. Maybe it's only in vulnerable people. So the effort to do this etiological research is becoming more and more. If you have identified the cause, then you can do the intervention research, finding the best interventions to reduce exposure, to change lifestyle behavior. Sometimes it's also technical measures. But very often you do not find a one-size-fits-all solution. So the implementation research is very important. And this is also a kind of developing field. I mean, how do you take the local conditions and the local context into account that your interventions that you identify to be successful also work in the population where you want to make it work. So there's some good news. As I said, for about 40% of cancers, we know theoretically how to do it. And for Europe, this has been summarized in the European Code Against Cancer, which gives at the moment 12 recommendations to people how you can reduce your risk of cancer. And of course, this is the usual suspects that I showed on the first slide. We are at the moment updating the European Code Against Cancer, and hopefully in the autumn, the 5th edition will be launched, which is an update on the science, but more importantly, for the first time, it also includes recommendations for the policymakers, so that we can say, look, these are the policies that have worked elsewhere, and hopefully across Europe, then it can also harmonize on this kind of policy level of what you're doing. So for instance, when we talk about the UV again, I mean, protecting children from the UV exposure means for policymakers, you also have to provide shade in schools, in kindergartens, that the children have a possibility to avoid the sunshine or provide a proper clothing. From the European Code Against Cancer, we thought that this is actually a concept that should not be only limited to Europe, but work for the whole world. And this is why at the agency, we had launched the World Code Against Cancer framework. So if you're coming from continents saying, oh, we want a code as well, please contact me. And I put some leaflets here on the table that actually you see what this program is. We had launched the first edition of the Latin American and Caribbean Code Against Cancer, in fact, 2 years ago, and we are already working together with Asian teams of making this happen in Asia. Unfortunately, what is always a little bit of a barrier that this is not an exercise for free. So if you find $1 million in your pocket, don't be shy. The code would benefit from it. So now finally, Cancer Prevention Europe. So this is our network. The steering group is at the moment 11 core members, which is really, I mean, the major cancer prevention institutions from around Europe. So you see the Danish Cancer Institute, you see the Institute of Oncology from Milan, you see CRUK, Imperial, I don't name them all, DKFZ, for instance, INCA, we have here. I mean, many of you sitting even here in the room. So it's a collaborative network of cancer research institutions and was created in 2018. And the coordination is at IARC, where we have the scientific secretariat. But I think an important comment I want to make here, usually I'm talking here about the scientific secretariat, but we shouldn't forget that, you know, and I know in the afternoon we are talking about international collaboration. We don't need a new infrastructure for every international collaboration that we want to do. So the advantage here of putting this at IARC is not only our scientific role, but at IARC, you know, we do have an accounting system, we do have legal advice for making contracts, we have travel policies in place. So all these kind of, you know, bureaucratic things don't have to be reinvented if you put your network to an institution that's existing. And that's really, I think, a recommendation I want to make, because at the end it's cost saving, and the, I mean, the resources we have, we can really put into the prevention research. So the mission is really filling the gaps in evidence for prevention. It's shaping the EU cancer research agenda to avoid pitfalls in the recommendation, and of course, sharing the capacity for training and quality of improvement is also an important objective. So this Cancer Prevention Europe could also be used as a blueprint for other regions of the world. And I mean, our workshop here is also on inequalities. And I want to show you really some inequalities here by bringing in the research of the agency that we are doing in sub-Saharan Africa, and Dr. Weiderpass introduced you yesterday already to the African breast cancer and disparities in outcome study. And this is one of the diseases, the breast cancer, where we have cure rates in Europe and North America, I mean, around 90%, and unfortunately, sub-Saharan Africa, this is way below 50%. Come in, please, it's ringing. Oh no, that was Anta. Okay, it's all very small print, but I want to look at the colors. So what you see here in the blue bars, this is actually the real 3-year survival in these different countries. The very high bar on the left, this is the Namibian but white population, and the 3 on the right, this is Uganda, Zambia, Nigeria, where we have a 3-year survival below 50%. And what we did here was estimating and saying, well, if the health infrastructure that's available already in the country can be optimized for each country, you could achieve this higher survival by not turning the healthcare system upside down. And these green pieces that you're seeing here, this would be making an earlier diagnosis, so the effect of the downstaging. The red bar would come from providing complete treatment, and the orange bit would be education and reducing the gaps in socioeconomic status. So you see there's already an advantage, but even if, you know, put all the, what is already available as opportunities in the country, 90% that we have in IGAP countries. And that's also an example where you see the interplay between IARC and WHO, because WHO was picking up these results and created the Global Breast Cancer Initiative that now is really working on increasing breast cancer survival throughout the world. And other examples are the research in childhood cancer, where we have a similar situation. The lymphoid leukemia, 90% survival now in Europe, less than 20% in most of the sub-Saharan Africa. Cervical cancer, we heard a lot, and also one of the situations that we are now starting at the agency, that's people with albinism in Africa, where the squamous cell carcinoma is actually a common cause of death, and this is really not the case elsewhere in the world. So the conclusions: 40% of cancers are preventable. Research into causes remains a priority. The intervention studies are needed to optimize the preventive potential, but we also need a more rigorous implementation, and we need more implementation research because obviously we have not yet found the best ways of how to implement our preventive ideas in the populations. The international collaborations are key: the joint research, the joint advocacy, eliminating implementation barriers. Cancer Prevention Europe can be used as a blueprint for other regions, and in these international collaborations, we should never forget, use the infrastructures that are already existing instead of building up more and more and more and more independent new infrastructures. I think that's very important, and now I'm finished. Thanks for your attention.